Good morning. This is Lisa with the Oley Foundation. We are here to have a presentation by Kathleen Gura on IV drug shortages. We're thankful that Kathleen is willing to do this for us, and we welcome her. I wanted to say that today is the second day of our 2018 Home Parenteral Nutrition Awareness Week, HPN Awareness Week. And in honor of that, we're doing this webinar. We're doing another webinar on Thursday on the complications of home parenteral nutrition, what to do and how to minimize. That's from 1 to 2 on October 18th with Dr. Kelly and Dr. Ann Mikulek. The HPN Awareness Week is designed to help spread the word that many people live full and rewarding lives while relying on HPN to meet their nutritional needs. And part of our goal too is to present educational presentations and webinars to help people who are on HPN have maximum quality of life and minimize complications, and to help preserve the quality of life. So without further ado, I'm going to introduce Kathy Gura so she can get on with our presentation today. Kathy Gura is the Clinical Research Program Manager and Clinical Pharmacist with the Clinical Nutrition Service in the Division of Gastroenterology, Hepatology, and Nutrition at Boston Children's Hospital. She is also an Assistant Professor of Pediatrics at Harvard Medical School and Associate Professor of Pharmacy Practice at the NCPHS University in Boston. Kathy's professional focus is on academic clinical pharmacy and research, and her topics of expertise include management of intestinal failure and nutritional support for the critically ill pediatric patient. Certified as a nutrition support pharmacist, Dr. Gura is a fellow of the American Society of Health System Pharmacists, the Pediatric Pharmacy Advocacy Group, and the American Society for Parenteral and Enteral Nutrition. Kathy is the recipient of numerous awards, including the 2012 Distinguished Pharmacist Award from the American Society of Parenteral and Enteral Nutrition, or ASPEN, and the 2008 ASPEN Serlick Award for Safe Practice in the field of parenteral nutrition. Kathy was also awarded the Drug Therapy Research Award by the American Society of Health System Pharmacists in 2009. She has served on several expert committees involved with USP 797 and USP 799, and has authored over 150 peer-reviewed publications and book chapters, and her research has been funded by the March of Dimes and the FDA's Orphan Drug Development Program. Kathy, we're thankful you're here. We're grateful to have you, and we look forward to hearing what you're able to tell us about IV drug shortages.
Well, thank you, everybody. It's an honor to be able to speak with you today. Thank you, Lisa, for the kind introduction. What's this? Okay, these are my disclosures. Just as an aside, I know people get upset when they see people disclose, but realize that a lot of medications aren't brought forth from research to the patient unless you collaborate with industry. And if it wasn't for these collaborations, we wouldn't have a lot of the new products we've brought forth in recent years. For today's talk, I'll talk about the history of drug shortages and its current state, how it impacts PN safety, what we do to identify patients at risk, as well as recognizing some of the signs and symptoms of more common deficiencies, and the various resources we use in practice to manage shortages. And by definition, the FDA defines a shortage as the period of time when the demand or projected demand of a drug within the U.S. exceeds the supply. And the standards for determining that if a shortage exists really means that the manufacturer has decided they can't keep up with the market demand based on their information. The shortage occurs nationwide, so it can't be just a regional shortage. And it's determined by the supply of the drug at the market level based on the information that the manufacturer and IMS Health provides. And this is not a new problem. We've had shortages going back since I was a new graduate back in the 80s. So showing you graphically, it's actually not as bad as it was even 8 years ago, but was actually getting better. However, PN shortages have been ongoing since 2010. Pretty much every additive I use in PN compounding has been impacted at some point in time. And this is just showing you all the different things that have been in shortage at some point in the past 10 years. And the reasons for drug shortages are multifactorial. It could be a problem with the raw materials, quality at the manufacturing level. Simply they couldn't keep up with demand. It could be a loss of a manufacturing site. We'll talk about that in the next couple of slides. Or simply a manufacturer decides they no longer want to manufacture a particular product. And because they're so complicated to compound, injectable medications seem to have a higher proportion of the shortage volume in comparison to tablets or topical medications, for example. And as you can see, pretty much all our shortages have been focused on the injectable market. And when we look at the 2016 data, this was provided by the University of Utah Drug Information Service. More than 50% of the time, we really don't know what happened, why that manufacturer is having a problem with their product. A third of the time, the manufacturer does report it's a problem at their level. 15% of the time, they'll say it's a supply-demand issue. 1% say it's simply a regulatory issue that they're addressing, or 3% have said it's, they decided no longer to make it. But half the time, we really don't know why this drug is in shortage. And when we talk about the specifics with injectable medications, again, a lot of it's related to quality, again, probably related to the difficulty and the complexity of making an injectable product. So as a result, that adds more of a challenge to the marketplace. And in fact, things were being addressed. The industry was responding, ramping up their facilities, meeting compliance, and things were definitely getting better over time. In fact, up until second quarter of 2017, our numbers were getting a lot better than they were even a couple of years ago. And the reason we had those shortages in the past 8 years was mostly because there were increased regulatory compliance requirements placed on industry by the FDA. And what the FDA does is they increase the number of warning letters that they send to industry saying that there's a situation that they have to address. From 2009 to 2010, there was a 42% increase in these warning letters. But that even in the following year, from 2010 to 2011, there was an additional 156% increase. And anytime a company receives one of these warning letters, they can't just ignore it. They have to address it. And oftentimes that means the plant has to go offline, it has to shut down. And when that happens, the competitors simply can't upload or upregulate or up-manufacture to meet the market demand because the manufacturer plants are not used for one product. They use them for different products. So they simply can't decide to increase their capacity because they may have to make another medication at a different point in time. But overall, as a result, there was a 30% reduction in capacity to supply the U.S. market with the injectable drugs as a result of this increased regulatory compliance requirements. And another reason, and one you're probably more familiar with, is natural disasters. Last year was terrible. We had the perfect storm. First, we had Hurricane Hurricane Harvey in Texas. And when that happened, the oil wells were knocked out of commission. And oil is a big part of what we use for making injectable products. I mean, for the plastics, the tubing, the bags. And then very shortly thereafter, Hurricane Maria hit Puerto Rico, and that knocked out a major manufacturer of IV fluids and amino acids products. And that's what caused the most recent shortage we just experienced. There's also what's called voluntary recalls. Every day, hospitals and pharmacies receive notifications from manufacturers that a specific lot number is being recalled because it doesn't meet their criteria for quality. It might be a discoloration, maybe the labels has misinformation as a wrong typographical error. But anytime they have to remove that particular lot off the out of inventory, and those are all generated by the manufacturer, and that's not even governed by the FDA. Other reasons that happen for drug shortages is simply supply and demand. Again, maybe we use a drug that was approved for one indication, and all of a sudden somebody's decided to use it in a different manner, and the use increases. A great example, even though it's not nutrition related, was the medication called Terbutaline. They used to use it in labor and delivery, but people saw that it worked very well in asthma, and when that happened, they couldn't keep up with supplies, and they couldn't even change the packaging to account for the increased volume of drugs. So it really caused a problem because the manufacturer was totally taken off guard. Another situation, unfortunately, that happens when we learn of shortages is that people start hoarding. You learn about a shortage in one part of the country, you might learn from a home care company or a family, and we'll often respond by ordering additional drug more than we typically use just to make sure we don't run out. We typically won't want to loan to other facilities because we want to make sure our patients don't go without. And again, another reason for a drug shortage could be a discontinuation of a product. Great example of that is that around 10, 15 years ago, there were actually more than one manufacturer of IV multivitamins. Well, one of those manufacturers suddenly decided they no longer wanted to make IV multivitamins, leaving the other manufacturers holding the bag, and they simply couldn't respond to that void in the marketplace. And we had a vitamin shortage back then that was a serious problem. It was simply a manufacturing decision no longer to make the product. Other reasons could be simply a lack of available raw materials. Simply a disruption in the supply chain can cause a drug shortage. A great example of that happened many years ago in Japan, where one of the raw material for the medication piperacillin was manufactured. They had a natural disaster, so there was no piperacillin to make the Zosyn injection we use in practice. It was simply because the raw material was not available. And as we saw last year with Hurricane Maria, there was a loss of a manufacturing site. And even when they do fix the facility, it has to be re-inspected by the FDA. And sometimes it's simply a lack of resources to respond to these inspections and recertify the plant and the processes in a timely fashion. At any time a manufacturing site does go down, there could also be a problem that they have to be re-inspected before they can go back online. And they simply may not have the resources to do it as quickly as we'd hope they could. Quality issues are another big factor for drug shortages. Products that might have a contamination, either fungal or bacterial contamination, they have a bad lot, they'll pull it off the line. Sometimes there'll be particulate matter that's been reported, like fibers or glass or metals in the vials, or crystallization or precipitation, and that will result in a product being pulled back and recalled. And you may remember that several years ago there was a worldwide heparin recall because the raw material that was used to make heparin was processed in China, had a toxic contaminant, and that caused a worldwide heparin shortage. Another reason for shortages also could be misuse of a medication. I'm not a big fan of Simon Cowell, but he's a big fan of multivitamins, and there's been a big movement if you go to either New York or Los Angeles, where they have these clinics where patients who do not require specialized nutrition support like PN get their daily vitamin infusions so they can continue to look beautiful. And as a result, we had situations where vitamins are not being used for patients, but for celebrities. In fact, Aspen did respond with a position paper on this whole movement of using vitamins inappropriately, and this is just the reference here. It just brings to mind that, we have to, if we see these situations, you want to let the Aspen office know, or you can even let your state representative, your congressman know, because this is compromising patient care. And in some instances, you don't even know if these vitamin products that they're using for hangover clinics could be even of high quality. They could be made by compounding pharmacies. They could be made by they may not even be using a commercial product, but we don't know what they're using, but we do know it's being used inappropriately. The Institute for Safe Medication Practices had a survey on PN shortages that they wanted to understand how these PN additive shortages impacted both patients and practitioners, and how the market reacted to the use of imported PN components, because that was something different in the most recent series of shortages. The survey looked at the deficiencies that we experienced in our patients. Were there errors because of mix-ups between the adult and pediatric products? Were there different dosing errors because of the different concentrations? Maybe you're used to using one concentration and you were forced to use another. Or operational issues out in the pharmacy. Maybe you didn't update your computer system appropriately or change your compounding settings. And in fact, of the people who were surveyed, almost 2/3 reported they had to use imported PN components, and we did as well in Boston. What the survey also showed, though, was a high level of frustration and a low level of safety. That was a major concern among patients as well as practitioners. And one of the major problems was we really didn't have any information or any good quality information about how long this shortage of a drug was going to, how long was it going to be around. We would, in fact, in my institution, I have to meet twice a week just to discuss shortages. I meet once for a hospital-wide level on all the different products we have in shortage, and then my TPN team also meets separately to discuss how it affects our inpatients as well as how does it affect our outpatients. So, I mean, it does take up a lot of time. We also don't get advance notice when this happens. Usually how a pharmacy finds out about a shortage is you place an order and then all of a sudden you don't get a delivery, and then you call up and say, where's my whatever? And they'll say, oh, it's on back order. And then you find out it's more than just a back order. They're not making it, there's a shortage, they've been recalled. That's how you find out the magnitude of the problem. And often we learn it's a problem, but we don't know what the problem is. So we very little, most of the time we never know what the cause of that shortage is. Other things we worry about, like as I mentioned before, we spend a lot of time investigating shortages and developing an action plan of how we're going to address it, how we're going to manage the remaining stock, who gets what. Often we have to have trouble obtaining suitable alternatives. Often we have to buy things off contract. Every hospital pharmacy tends to enter a contract with one of the major manufacturers. And anytime you buy, you get a better price. And when you go outside that contract, you can be penalized or you have to pay the premium cost because there is a loyalty for staying with one manufacturer. So as a result, there is a significant financial impact. And in some cases, there may not be a suitable alternative product. During the bag shortage, the automated compounders have to use specific kinds of bags. And if you run out, you can't compound the TPN. You can't just use another kind of bag. So we had to be very careful of rationing and managing our supplies so they didn't get wasted. Again, we also spend substantial resources on either making things from scratch or administering alternative products. And so we oftentimes may have to use special outsourcing facilities to help fill the void. So there's always a risk of, when there's change of adverse patient outcomes, that's always a concern that we have in the back of my mind. We don't want problems to happen, but we're always looking for them to make sure they don't happen. We don't want the hoarding to happen because of the shortage situation. And sometimes physicians and other practitioners may not be aware of all of the things that are going on in the background of why these are happening, why they're being asked to change their orders, why can't they get what they ask for. And sometimes, especially in hospital situations, maybe they're challenged on, is it really appropriate that a patient start TPN? Maybe they should be receiving enteral nutrition, for example, instead, and they don't want their practice challenged, but sometimes they had to reevaluate their practice because there wasn't enough to give everybody what they needed. So let's talk a little bit about the effects of the shortage on patient safety. This is actually right down the street from the FDA is Children's Hospital National Medical Center, and they actually had a situation where they had a shortage on zinc, and they had patients that were negatively impacted because they had a zinc deficiency. So what happens when you have a shortage? Again, you have a negative effect on drug therapy. You may have to treat other complications that result. You may have to compromise or delay procedures if you don't have what you need. Medication errors can occur because people are using products they're not familiar with. As I already talked about, there is an increase in drug acquisition costs, especially when you go off contract. There may be increased labor costs because sometimes you have to use a very convoluted system or do more extemporaneous compounding to make products that you otherwise would have bought from a manufacturer. And in my case, we do a lot of translational research on parenteral nutrition. Our lab actually shut down for a year because we could not use the TPN components for animal studies when we needed them for our patients. So it actually stops clinical research too and translational research. So again, as I mentioned, there was a lot in the news during this whole time regarding the shortages. And there were many errors and preventable adverse effects that occurred during one of the shortage periods. There were vitamin deficiencies that were reported when patients didn't get adequate doses. Sometimes they would use the inappropriate, mix up the pediatric and the adult product, not use it in the right patient population. We're currently in a phosphorus shortage situation, and errors have happened when people use the different form of phosphate salt that they're not used to. For example, when during a potassium phosphate shortage, patients got high sodium levels because they were substituted with the sodium phosphate, potassium phosphate. And sometimes some hospitals had no phosphorus and infants experienced fractures because of hypophosphatemia. Errors have occurred when people didn't pick up on the difference in concentration on potassium acetate salts. It comes in 2 strengths. And in one situation, they were used to using 2 MEQ per mil concentration, and they had to substitute their production to 4 MEQ per mil, and it wasn't picked up. Also with trace elements, we've had multiple trace element shortages, and some people were doing it several times a week as opposed to daily. And what happened was people may have forgotten and the omission continued, or they used a different product and they may have made a dosing error. So again, anytime you're doing something different than your routine, you're opening yourself up for an opportunity for error. So what does the FDA do to prevent shortages? What they can't do is make a manufacturer increase production. They can't make the manufacturer change its distribution method, like, for example, reserve all their components for just home PN patients or just for children. They can't change the distribution, and they can't make a manufacturer produce a drug. So if somebody wants to stop making something, they can, and the FDA can't make them make it. What they can do to help during these times of shortages is allow temporary importation from unapproved venues. So we experienced that. We brought in different products from Europe during these different trace elements. We brought in some phosphorus salt alternatives. We brought in different vitamins, as well as amino acid products to cover us until the U.S. market, the U.S. facilities could improve their production. Another way the FDA can help is if there is a product that's going to be brought in by the U.S. manufacturer, is to expedite the review process so it doesn't delay it. So what else does the FDA do is sometimes they can do regulatory discretion. For example, there was one shortage involving phosphorus salts where the product had particulate matter, and rather than simply throwing all that product away, they updated the package insert and put a little supplemental information in saying you had to use a filter to capture that particulate matter. So that way we got the phosphorus without compromising and having a shortage situation. Or they may ask the clinician to double check the volume for overfill. Sometimes they'll contact another manufacturer of the same product to see if they can accommodate and produce their volume. If they can, they will, but if they can't, they can't make them. Again, the expedited reviews. And sometimes they'll even change expiration dates on products. And this website link on the slide, if you're interested, just gives you an example of how expiration dates were extended. Now, what else they also established was the FASHP Act, the FDA Safety and Innovation Act. And what that did was require that the industry notify the FDA whenever they suspected they're going to have a shortage or they're going to stop manufacturing a product that's going to impact a life-saving or life-sustaining medication. And so since 2011, the FDA has collaborated with the industry to avert more than 1,000 different drug shortage situations, of which 75% involved injectables. So, I mean, FDA is working with industry to make sure that there's some method to the madness so patients don't go without. So what happens if a manufacturer doesn't comply with FDASIA? They will be issued a letter and a penalty if they didn't comply with the notification requirements. The whole idea is directed that the FDA is developing a strategic plan to prevent and mitigate drug shortages. So they penalize industry if they don't comply with the notification requirements. So what about management strategies? The American Society for Parenteral and Enteral Nutrition, FASPEN, is an excellent resource that uses experts to come up with guidelines of what to do when a shortage situation is suspected. The first thing and most important thing you can do is start your conservation strategies early as possible. And another big thing is to assess that need for parenteral nutrition. Sometimes there are things we can do that to not use up all our PM materials for patients who may have other alternatives. They also may encourage switching to oral and enteral alternatives when it's safe to do so. And then they really emphasize reserving those IV products for those patients who have a medical need for IV nutrition, such as patients with malabsorption syndromes, the vulnerable populations like the neonatal population. And again, FASPEN comes up with guidelines for both vitamins, trace elements, fat emulsions, amino acids, as well as electrolytes and cysteine. And they remind people that the PN orders have to be updated, their format, so the prescribing errors don't occur. But FASPEN is very proactive in this approach, and a lot of the other organizations will link to the FASPEN site so that everybody has the same information. Also, as we talked about before, ISMP reminds people whenever we have a shortage, we want to error-proof our system. So again, these are the key points I talked about before, was making sure that we don't delay treatment. We have prevent adverse events by looking for alternatives in advance. Make sure we are proactive and not reactive. And again, just trying to prevent errors before they occur. Other things we also worry about is the whole issue of the gray market. Sometimes providers are going to be approached by people who have alternative supplies of components. And sometimes these are not authorized wholesalers or manufacturers, and you just don't know what you're getting. We don't want to do this. We don't do this. But that's something you should be aware of. You'll see, again, you might see this advertised. You don't want to buy on the gray market. You don't know if it's stored properly. You don't know if it's the high quality of the manufacturer. You want to make sure you have a chain of custody from the manufacturer to the wholesaler to the pharmacy and ultimately to your home. So you want to avoid the use of any of these alternatives, no matter how appealing it sounds. For therapeutic options, sometimes we will change our practice and our compounding. Right now, for example, we changed our preferred phosphorus salt from sodium phosphate to potassium phosphate, simply to conserve supplies. We also, on several occasions, imported from abroad. We used the organic phosphate salts, the glycophos, when we were able to, as an alternative to other phosphorus salts. We brought in the vitamins, Cernavite. Baxter worked with bringing that in. The trace elements, we brought those in from Norway. So the FDA does work with industry to bring in these products, and once the shortage resolves, they do go away. So, but it does help us get through the time of the shortage and make sure patients don't go without. And again, the conservation strategies as outlined in like those various FASPEN position papers. So again, here's an example of some more FASPEN recommendations on how we conserve PN products. We don't want people to abuse some of these precious ingredients for maintenance fluids if the patients don't need them. They also want people to look at their guidelines and protocols and reevaluate and reprioritize in times of shortages, and look at what the alternatives are and see if they can. Sometimes this is how people end up using the commercially available pre-mixed PN solutions if they're able to. That's carried through to help some patients who were able to get their PN using standardized products whenever possible. So it's, again, it allows you to conserve supplies for those patients who cannot receive a commercial premix. This is an example of vitamins. Like I said, I know of at least 3 different times we've had vitamin shortages since I've been in practice. And again, there's guidelines. Like, for example, the big reminder is we can't use the adult products in babies because babies are very prone to the toxicities of the excipients in the adult products, propylene glycol and polysorbate. These babies can't metabolize it, so it can cause adverse effects if the baby gets an adult multivite. They also have different guidelines if we have to use the adult products in older children. Again, sometimes you simply run out of a vitamin. So when you don't have the complex multivitamin product, you want to make sure that thiamine, ascorbic acid, pyridoxine, and folic acid are given daily. That might be as individual additives. Again, I just mentioned the toxicity that's seen with the pediatric, when neonates in particular get the adult products. And again, the pharmacist should be aware of this. With trace elements, there were very specific guidelines that the FASPEN team came up with for adults. Again, they wanted us to reserve the trace elements for patients who are 100% PN compliant if they were getting combination of parenteral and enteral nutrition, that they would suggest maybe dose reducing. And again, if you ran out of the multi-component trace element product, you use the individual trace elements for the duration of the shortage. You're probably more familiar with the amino acid solutions. We did, because of the hurricane last year in Puerto Rico, and well as a manufacturer not making amino acid solutions, there was only one manufacturer in the US at one point. And there was talk about substituting adult amino acid solutions with the premature, for those intended for babies, and that's not a great idea either. If you're giving a baby the adult amino acid solution, they simply don't grow as well. We also, for the adults, would use premixed PN as a source of protein. But probably what you most commonly saw was substituting one brand of amino acid for another. In fact, we imported one particular company was able to bring in their European amino acids over to the U.S. market for the time being. And so they're slightly different in composition. So again, that's something else you maybe have seen in your practice. We already talked a little bit about phosphorus shortages. When we totally ran out, we had to go to oral supplementation. Sometimes we also had to think about how the fat emulsions, which have phosphorus in their formulation, may be helpful in helping mitigate the shortage. And then in my situation, we were actually using Fleet's enemas for some of our kids to get phosphorus. For nutrient deficiencies, again, that's something we want to avoid. This is an example of a zinc deficiency, this awful rash. Just bringing to your attention, again, trace element deficiencies oftentimes look like something else. That's one of the things that makes it a challenge. They're very subtle. Often they take a long time. They don't happen overnight. And even doing a zinc level is not, or blood value may actually be a poor marker of overall zinc status. So it gets to be a challenge for practitioners unless they have a really good history. Also, there was, like I said, there was deficiencies reported in the literature. In fact, one child did die, and that actually drove the message home because it happened right down the street from the FDA. Selenium deficiency also occurred. In fact, this is one of the trace element deficiencies that people picked up in the early days of home PM because it wasn't in the commercial products. And we have selenium deficiencies, cardiomyopathies, different kinds of anemia, and again, very subtle because it looks like something else. The most important thing, if anything, I can impart to everybody listening to this is that if you don't have vitamins with your TPN, you got to make sure that you get thiamine. Thiamine is critical. It has to be given parenterally whenever you have a vitamin shortage. It's not appropriate for somebody to be given oral multivitamins to a patient who's PN dependent. There's a reason you're on PN, and you definitely need to have the thiamine, that particular vitamin, given parenterally. You can't just give them take a tablet. This is the dosing, just for your information. If you don't have thiamine in your diet when you're getting a lot of dextrose, you could see cardiac side effects, beriberi. You could see a neurologic side effects such as Wernicke's encephalopathy and metabolic lactic acidosis. So, I mean, this is serious. I mean, people say it's only a vitamin. Well, this is a very important vitamin. So if you get a delivery sent to your home and the vitamins aren't there, you should always pick up the phone and call your home care provider and find out what's going on. But this is a serious problem and one of the major problems that happened during the shortages. So how do you know when the shortage is over? That's another challenge. Because sometimes we live with these shortages and we never get told that, guess what, the drug's back in stock, there's no shortage. By definition, the FDA defines a shortage being over is when one or more manufacturers can actually meet the demand. The American Society of Hospital Health System Pharmacists actually is more stringent. They say all manufacturers are able to restore all strengths and sizes of their package of that product. The product is available through the normal wholesale channels. You don't have to order direct from the manufacturer. It's easy to get. And you can give the dosage your patient needs. That's how you know a shortage is over. You can give everybody who needs it the drug they need. So in summary, drug shortages are an ongoing problem. They also pose a significant safety risk to all patients of all ages, especially our neonates and pediatric patients, but also the patients that are dependent on parenteral nutrition to sustain them. Anybody who's a chronic patient is at risk. It's become more challenging over time as our pharmacy rules and regulations have become more complex. And you have to have a plan in place to constantly monitor and anticipate shortages and know what to do when they occur. We try to not ration everybody. We want to only be sensible about this. We don't want patients to be underdosed. And our goal is always to give all the patients what they need, give them the full daily dose. Here are some resources that you may find useful. Just want to remind everybody, not all home care pharmacists and not all pharmacists that work in hospitals who deal with parenteral nutrition are members of FASPEN. So don't assume all people that provide parenteral nutrition are aware of these guidelines. Some are, some aren't. And sometimes you may have to educate them. And these are some of the websites that have information. The FDA has information as well as ASHP and ASPEN. ASPEN is actually the best website because it has most detailed information. It tells you what to do. Not just telling you there is a shortage. They actually tell you what to do while there's a shortage, how to manage it. And that's very practical, evidence-based information. Joint Commission as well as CMS. Also, if you have a situation, you want to share your story that you had a problem, you may want to report it to these organizations just so they are aware that you had a negative event, so they can prevent it from happening to another patient or family. And these are just some of the case reports I just talked about. So with that, I will thank you, and we'll be available to answer any questions you could contact through the ASPEN office. Thank you.
Kathy, thanks so much. We really appreciate all that information. We know that those on HPN are often affected by drug shortages, and it's helpful to understand the causes and what healthcare practitioners can do. And Kathy mentioned that we can address questions. If you do have questions, please send them to the Oley Foundation at oleyfoundation@gmail.org, and we will do our best to get the answers to them and post them on our website, www.oley.org, under resources, and then you can select webinars. And that's it from us. We really appreciate your joining us. We hope that you'll join us later in the week for the webinar on the complications of home PN. Thanks again to Kathy Gura for her wonderful presentation. Thank you for joining us.